To find out what your medical debt doctor wants you to know, I reached out to Dr. Mary Doherty. Dr. Doherty is the founder of GHP Navigators, a medical billing and patient advocacy practice based in the New York City tri-state area that helps people navigate medical, financial, and social problems and overcome struggles with corporate, insurance, and government red tape. Dr. Doherty shares her doctorate in systems leadership and nursing practice, 20 years of expert clinical and quality healthcare management experience, and just outright pure straight up passion with patients and clients throughout the United States. So Dr. Doherty, first, thank you so much for taking the time to talk with me.
Thank you for having me. I really am excited.
So you know I'm excited because I've always been a fan of your outstanding, incredible patient advocacy work since we met years and years ago. I'm not going to say how many years ago. I'm not going to out you and me. I'm not going to date us, but since we met years ago, working to help keep patients with chronic and multiple medical problems out of the hospital and out of nursing homes. Can you tell us a few stories about patients that you've helped over the years? And I know you've shared a few with me. Like one of the stories I remember you talking about was a patient who had Medicare Advantage insurance and they were in the hospital overnight for like a night or maybe even 2 nights, but they got stuck with like a 5-figure bill, like 10 or 20 or $30,000 worth of bills because they were never formally admitted. It was just an observation stay. Can you tell us a little bit about that story and the issues behind that and why that happened to that patient and their family?
So the patient went emergency room and they said they told the patient and the family that mom was going to be admitted, but what they didn't say is that she's going to be admitted to observation. So observation really is just room and board. Everything else that goes with it, you have to make sure that they're in the network of your Medicare Advantage plan. If it is not, then you're going to have to pay either out of network pricing or it's not covered. So this was never explained to the family. They thought mom was being admitted because she did go to a floor. Because I did ask that question because in most emergency room observations on the same floor and they just have really stretcher beds for it. But no, they told me that mom was brought to a room. And then I found out that the hospital did have observation. I asked them, do you have a release? And did you explain that? Did the admissions person explain that? Because under the law, they're supposed to. So that was never explained to the family because there is a consent that needs to be signed for that, to say that they understand that it's just room and board, that everything else would not be covered during that step. So as I was looking through the paperwork, I was not able to identify that consent. And I fought the hospital. Of course, the hospital did take them to collection, but at the end of the day, the Department of Health proved that the hospital was in the wrong, but I had to take it that far and escalate it up that far. And then the other thing is CMS, his rule is that they need to tell the patient that they're managed care and that those items would not be covered. So the patient needed a CAT scan and the patient needed a specialty to come in. Both were not covered. And the bill was a little, I believe, like $30,000-$40,000. So, but at the end of the day, the patient paid nothing because the hospital.
And the patient paid nothing because?
Well, after the fight between,
right.
The hospital's telling me I'm wrong. And meanwhile, I'm throwing them at the regulations at them. I'm showing them state regs. I'm showing them CMS's regs on it. And they just, I think they thought I would go away, but I didn't.
They don't know you very well, do they?
So
they do not know Dr. Mary Doherty.
So it ended up being a zero bound for them because of the hospital didn't probably want to pay a fine because they would be fined for that. They told me that it was a billing error in their EHR.
Oh my gosh, we made a mistake. Oh,
there you go. So, and that's another thing is I always tell families when they see the balance billing, the first thing you want to do is tell them you want an itemized bill. And the reason being is a lot of times you can catch that in the itemized bill, because that's when I start to find out those services were never rendered. And especially if you're going in for the emergency room. But the other thing is, if you're going in for surgery, I am telling you, if there is a balance bill for that, definitely get an itemized bill, because that's when you start to find out that those visits were never made by those other specialties, those medications were never given. Because believe it or not, there is a formulary now in the hospital for some of the medications that aren't covered under the stay, that there's like a rider on and that you need approval for. And of course, we don't do that. So then the patient gets a bill for that too, where they don't tell the families, only they think they're covered when they come in and say you're financially responsible for anything else. Well, no, the law is very clear. If it's not a covered item, especially specialty medications, you need to get a consent, number one. And then the other thing too for that is that you need to also do a financial agreement with them if they decide, because the other thing you're allowed to do is if you have the medication at home, you can bring it bedside. And that's what I say to families.
So there's a few things here. So I talk about this a lot. I talk about this all the time. And the biggest thing that I tell people first thing is rule number one. There are 3 steps. The only right way to pay a medical bill involves 3 steps. And the very first and most important step is to call the billing department or the patient accounts department and ask for an itemized bill. And an itemized bill is a bill with CPT codes, just like barcodes products. When you go into a store, you take the product that you want, you wipe it through and it tells you the price. You don't know what you're getting. You don't know what you're paying for if you don't have a CPT code on the bill, right? So that's the number one thing that I always tell folks. And that is something that you're talking about, that no matter if it's outpatient visit or in the cases we're talking about, a hospital stay, always first call, first thing, first step, call the billing department, office manager, or patient accounts, whatever it is, the ones that are sending you the bill that deal with the money. Often it'll say on the bill, billing questions. That's the number to call. They'll say, have a number. That's the number to call to request an itemized bill with CPT codes. So thank you for bringing that to attention and reminding us of that. The other thing I wanted to talk about, Dr. Doherty, is balance billing. And I'm telling folks all the time that that's one of the top 5 reasons why most Americans are just one accident, injury, or serious illness away from a lifetime of debt and or bankruptcy, is because of balance billing. Can you tell us what balance billing is?
So the balance billing comes after the insurance pays what they're going to pay. That would be the balance bill. But in 9 times out of 10, it really is not your bill because of a couple of reasons. They went above the contracted rate. That could be number one issue. The other issue is that the transparency of pricing doesn't meet what they listed with the state versus what's on that bill. That's number 2 that I look at. And then number 3, if it was something that needed a specialized consent form for, I definitely make sure that that was in there. And when I say consent form, that would be a financial consent, especially going back to the medications. And that's a lot of times I've done a lot of work for, especially for cardiac and cancer drugs, that it's a consent agreement because it's not covered within the admission, the DRG, that diagnostic code that they're going to use and drop the bill with, it's not covered in that. So if it's something like that, the first thing I do is look for the consent. And then if there is none, then I start negotiating a rate. Organization, like I'd say, okay, I really want to see what your transparency fee is. And why do I say that to them? Because billing really doesn't know that law and they'll throw anything at you.
Exactly.
And they'll give it to me with the letterhead from the hospital, and then I'll check it out with the state. And why is that important? Is because when the state gets a hold of it, they're not too happy that they're saying it's one price to the state and another price to the patient. And surprisingly enough, with that new transparency law, so many people, they don't even know what they submitted to the state because they don't even match. Now, why is that important? Is that the hospital will get fined for it. The state will do a reasonable and customary rate. They won't do the transparency. They'll go of what was listed. They'll go below that rate. That I've gotten in New York State, believe it or not. I've gotten it in California and now in Florida. So, because they get a little angry with these hospitals because they were supposed to list the price, which some of them, but what the billing office has and what the state has doesn't jive. So that's when I start going to look, because the more times I stir up trouble, the better it is for my client, because they walk away with, if it was 40,000, they might walk away with like $1.50 is the most I've seen on a drug that they had to pay for. I've seen too that the contracted rate is a big problem, especially with surgeries, because they put those riders on there. And I sat back and said, well, wait a second, you went in for a knee replacement. So explain to me what these other charges are for. Did you do this? Well, no. Did you do that? No. And it always seems for people over 65, there's these extra cardiac charges on there. And they say to me, and I just sit there and go, they say it's included in the rate. And I go, well, that's funny, because in the itemized bill, it isn't included in the rate. You itemized it and said it was another rate. And that's how we got a balanced bill. That's the other thing too about bundle rates. All of a sudden, something's not included in the bundle, but it was never done and performed at the hospital. And that's when I start to go looking for the documentation. And if there's no documentation, I bypass the hospital, because I know if I bring this to the Department of Health's issue, because it's really falsifying documents, they'll walk away from it and tell the family, oh, it was an error in our EHR with the billing.
Apologize.
And that's and that's the first thing they'll say. So they get warnings and deficiencies, and then the patient gets but they get an apology to the patient, and they pretty much send me an apology, and then they walk away with zero. So it's just different things. You have to play the game. If they're going to play, listen, I thrive on that. Like, I'm not going to walk away too easily. So, they'll come back and say this, and I'll go, well, yeah, guess what? The reg says that, and the reg says this. And then when they sit there and think that you're like a nobody, they know you're somebody when the states, the feds, or somebody comes after them and says, oh, yeah, we should have listened to her a little closer.
So there's a few things in there, a lot of juice in there, Dr. Doherty. The first thing, balanced billing, is when your in-network and provider, meaning they accept your insurance, sends you a bill for the difference between what they charge, their charge master rate from the hospital, right, and what your insurance actually paid them. By definition, if they are in network with your insurance, if they quote unquote accept your insurance, they have agreed to accept whatever they pay for the services. Your insurance pays for your services, the care that they provide to you, as payment in full, completely paid in full. So even if they bill $100 and your insurance only pays $10 for a particular service, they cannot, by contract, they've agreed to accept it as payment in full and not come after you for the balance, meaning the $90 in this example. That would be a balance bill if they said, hey, this is how much we charge, your insurance only paid this. This is your bill. This is the patient's responsibility, which will show up on the bill under that category, patient responsibility, $90 in this example. And no, it's not true. You don't owe it. So that's the first thing that is super important that I talk to folks about all the time. And I talk about, in my book, but that is rule number one. Make sure if you have insurance that if it was an emergency and you get a bill, the first thing you do is call your insurance plan to see if the provider who sent you a bill is in network. So whatever the insurance pays them, that's all they're getting. They can't come after you for the rest. They can't balance bill you. That's the first thing. The second thing is, if it was an emergency, if you have a procedure that you need to get done, a test or a surgery, always call in advance your insurance again to ask them if surgeon or the facility where you're planning on getting it done accepts your insurance, is in network with your insurance. So whether you had an emergency and you have to call after the fact, or you're planning something that's ideal, if it's not an emergency, you have the luxury of calling in advance to make sure they are in network, meaning they accept your insurance, so you're not going to get balanced bill.
Right.
So that's a juicy thing. The other thing that is really important is, and this I didn't know about as an internal medicine physician when, I had an outpatient practice, is that there's something called an ABN, Advanced Beneficiary Notice, for Medicare patients. And I think that's what you're talking about in terms of the form that folks have to sign in advance if the provider, the physician, or the hospital facility, the facility, care facility says, look, you're going to sign this to say that you understand that Medicare may not cover this.
Right.
If there is no signed Medicare ABN, Advanced Beneficiary Notice, in your records, in your chart, you don't owe it.
Right.
If Medicare doesn't cover it and they didn't give you a heads up that Medicare may not cover this, and they didn't have you sign an ABN, an Advanced Beneficiary Notice, you don't owe it. You didn't sign it. Medicare is very clear. You don't owe it. So that's the other thing. And another thing, the third thing that is really important in your story, in this particular story, Dr. Doherty, is that I tell people an admission is not an admission. Just because you stay overnight in the hospital doesn't mean that it's a real official admission. And why that's important is because if it's not an admission, if it's outpatient, anything other than an admission, a formal admission, you're on the hook. If you have traditional Medicare, you're on the hook for co-insurance, 20% co-insurance. You're on the hook for 20% of 2 nights in the hospital, all of those tests. The thing is that, if I understand correctly, not just Medicare, but all commercial and government insurance recipients, patients or members have to be told by the billing department, by the hospital, hey, sign here. You're not admitted, right? You're just staying for observation.
It comes from admission. There's a form that tells them that they are on observation rate, but that's what the problem is that a lot of times that form has never been given to the patient. They're just admitted to the floor. And I think what happens is that they're overwhelmed, maybe the admission people, because ERs have been filled. But you know what? That's not the problem of my client. That's the hospital's problem. And that's what I say to them, that I understand about oversights, but I now have a family that might need medical attention because they're having breathing problems looking at your bill. So you're making these poor people worry, thinking their homes are going to be taken away from them. We're not going to be able to eat next week.
Exactly.
And it's just very sad in this day and age that this is happening. And then once you start the fight, and in most cases, I have to bring in an outside agency because hospitals billing itself, they don't want to work with you, but they don't want to hear it because I don't think they understand the rules. This is the generic thing. Well, that's what the computer spit out. Oh, well, let me explain to you about artificial intelligence. My brain and artificial intelligence understands the regulatory. So that's what I say to the billing people. They get upset with me, but you know what? I sit there and it's like the same people over and over and over again, and they find you to be a haunt. Like I can tell you, there's a big medical center in Jersey. They call me Satan. I love it because
that's a compliment coming from them.
Yeah. Well, Satan's on the phone again. Well, yeah, okay, that's great. But you can call me anything you want. I used to tell them, but don't call me late for dinner. That's what I would say.
Exactly, right?
But let's talk this out. And I want to point out what it states very clearly, especially in the managed care advantage. There's a lot of regs there that they're just not aware of. And the biggest thing was during the pandemic with these telehealth. So with the federal pandemic, when he gave out federal law about the telehealth, Medicare Advantage denied a lot of those telehealth bills, and families were billed. And I go, no, don't pay them.
Absolutely
because,
not.
Right. So But the other thing is this is where, the hospital, instead of billing the patient, what should have happened is that you should have had one of your experts. I don't know if they exist in the hospital, but if you do, reach out to your contractual people, provider network people, and say, hey, you know what, there's a problem here. We're getting all these denials from your people. Can we have a sit down and need to understand why? Because federal law supersedes what you're saying. And that's how it should have been handled. Because I had people like calling me and crying, like, because the bills were outrageous. I mean, I was like, I'm in the wrong business. I should have went into that telehealth business, I said, because some of the bills were like $2,000-$3,000. And I'm like, okay, if it was telemedicine, I would understand that. But telehealth, no, I don't understand that. But getting back to where the hospital was wrong, instead of billing and making it the patient's problem, you should have had somebody reach out to your provider relations people at the health plan.
Exactly.
Because hospitals, if you really think about it, have these agreements with only a certain amount of Medicare Advantage plans. They don't take all of them because they're not in the same geographic area.
Mhm.
So that's what I say to them. Like, what is it to have your people sit down instead of annoying all of these other people and telling them you owe these money, and you're being inundated with phone calls where you can make one phone call and make that end. And then I went like that. That would be too much thinking on somebody's part. And they don't like when you come back with that. But at the end of the day, I got to throw some humor in there, because sometimes I go, what are they thinking? Like, why would you want all these people upset and inundated with ridiculous phone calls when you can solve that?
Yeah, I do talk about that also in the book, in Crush Medical Debt, is that from my perspective and my experience, Dr. Doherty, is that the folks in the front line, the folks that are answering the phone in the billing departments, patient accounts departments, actually, they really do want to help. They're humans. They really do want to help. The issue is they haven't been trained.
Correct.
Once you have basic information, 99.9% of the population doesn't have the information that we're talking about, like we talk about in the book, Crush Medical Debt, that you're talking about. Just simple making a phone call to ask for an itemized bill with CPT codes, with barcodes for the medical services, not balanced billing. Those two things right there will save you, tens of, maybe even hundreds of thousands of dollars over your lifetime. Well, they, with the minimal training that they have, the folks in the front lines with billing departments, answering the phones, customer service reps, they just have that basic training. And so, they know that, 99% of the time, they've got it, right? So when you have a modicum of information, or when Dr. Doherty shows up, with GHP Navigators, they're overwhelmed, and it's not their fault. They haven't been trained. You have to ask politely to let them speak with your supervisor. Can I speak with your supervisor, please, for help with this?
Well, and in some cases too, what I find is that they'll have the supervisor has to call you back, but they don't. And you're calling and calling. And, remember at 30 days, I got people like crying and thinking they're going to go on credit reports, which they're not allowed to do. I got people crying thinking they're going to come next week with a subpoena to take their house. And I'm like, no, I said, it's on record. If it goes to court, we need to show them that this is on record and what we need to say to them. And we spoke to certain people, so they need to do their part. And that's when a lot of times when I finally do get to the supervisor, they'll pull it back from collection, because it's not artificial intelligence telling them what to do. It's a real brain that understands the reg, explaining it to them. And they're saying, oh, okay, I see where you're going. Or you are correct. Or this was a computer error. Or it was, blame it on anybody else but the hospital, which is fine. Listen, I say to them, you can blame it on whoever you want. At the end of the day, all I care about my client is that becomes either a zero or there could be a deductible.
Yes, there's a couple of things with that too, along those lines of, the folks that are answering the phones, the human brains, they're trying their best. They haven't been trained. And your point about AI, the computers, they often have not been programmed. Their systems have not been updated to, let's say, the latest pricing, the No Surprise Bill Act requires transparent pricing for all their services that they offer. Okay, well, often that doesn't get updated in the computer systems and the networks and that kind of thing. So, AI is only as good as the human brain that updates it, right?
Correct.
So, yeah, it doesn't matter what their computer says. You're going to have to get more help, politely ask their supervisor to call you back, or can you speak with their supervisor? And if you don't hear back from the supervisor after that initial conversation and you're taking notes, you have a battle journal, I call it, just a notebook and just the date and the time you spoke with the person, politely ask for their name. Who am I speaking with? Thank you, Dr. Doherty, thank you. And you write down their name and the date that you spoke, and just a one-line summary at the end of the conversation, what was agreed to. The supervisor is going to call me back. This is what Dr.
Right.
Doherty said. The supervisor is going to call me back. And so if that doesn't happen, well, when do you think the supervisor will be able to give me a call back? Well, I don't know. She's very busy. Okay, well, do you think it'll be today? Do you think it'll be next week?
Oh, no,
Blah, 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 blah.
Mary doesn't do that. Mary starts
Mary
escalating
D
up
does
to
not do that. How do I know that?
I'm only waiting 48 hours. And then after 48 hours, I go to the president's office, believe it or not. I will do that. Because at the end of the day, my time is just as valuable as their time.
Exactly.
But I always have to worry about client. And why do I worry about them? In most cases, they're elderly, they have a chronic condition, and no matter what I tell them, they're still worrying because they're panicking with me saying, is this going to be resolved? So I, at the end of the day, have to worry about their health. And that comes from the clinician side of me going, okay, you know what? I just need to even this out. So I will call the president's office and listen, I'm never going to speak to the president of the hospital, but I do speak to somebody in there. And believe it or not, somebody from that billing office calls me back within that day. So, and
funny how that happens. Right?
I know,
Yeah.
but
Goodness.
at the end of the day, it's just, I don't want to be your haunt. And again, listen, that one hospital I spoke about before in the system that so many times it's frustrating, but as much as I'm frustrating to them, they have to understand there's an end game here. I don't want that patient back in the emergency room with a heart attack or with hypertension because of a billing issue that now they're going to accumulate another bill.
And hypertension because they think that they're going to owe all this money. So they're starting to spread out their meds. They take their meds every other day instead of every day because they can't afford it, because they think they're looking at this $40,000 bill or $90,000 bill or $140,000 bill. Exactly.
Well, I had another one with Medicare Advantage too, that this was down in North Carolina. Believe it or not, this was a referral that came to me. So it was pretty interesting that the Medicare Advantage paid for the stay. And I was like, so I reviewed the notes, I reviewed everything, I called the facility. I needed to understand like how that was submitted. Did they ask for notes? Did they ask for this? And that, believe it or not, that was the first time ever I did with CMS, went to arbitration, which was pretty cool. Anyhow, because the minute that the health plan listened to what a real judge, and I'm going, oh my God, I have to call this person, Your Honor. I didn't realize it was a real judge from CMS and said, why are we here? And I said, me? He goes, oh no, I'm not asking you. I'm asking the payer. I don't understand why we're here. He said, because the bill was a little over $240,000 and they didn't pay anything. They didn't give. And the reason for non-payment wasn't really defined. Usually it says, look at this code. It was something I've never come across before. And nobody from the insurance plan would speak to me. But that was pretty cool though with the CMS. Not only did they tell them that they had to pay the bill, but they said, I want that check cut today. I want you to call this person and I want to make sure that was overnighted to the facility. I was like, oh, I think they're mad at you to
You
myself,
think?
but
Exactly.
that was a lot of work from myself with the help plan, like meaning no one. They didn't, because I think they didn't even understand what the denial was for. But if they didn't understand it, like I said to the two medical directors, and I made this point to CMS, why did they not review the case themselves?
When you say the medical directors, you mean the medical directors for the Medicare Advantage insurance plan?
Correct.
Correct.
That,
Okay.
so when this was going right before arbitration, I think this was the first time that they were even put up against arbitration with CMS, because I didn't think they thought I would push it that far, but I did. And it was when the medical director, he said, the judge asked me, he said, I have to ask you a question. Did you speak to these two? I said, in the notes, look at the page, this page, that page, this. And he goes, again, why are we here? Why did you not review this case? So ignorance, I don't know, but I really do believe in some cases that medical directors in some of these facilities say they looked at something and just continued with the denial, and they never reviewed the case. And I
Rubber
think when this
stamped
hit
it.
there,
Yes.
right.
Yeah.
And I think they enforced what was originally there, and they weren't going to overturn that. But
Upheld the original denial. Yeah. Rubber
right. And I
stamped and
think,
upheld the original denial.
and I think this, in their case, this played against them, because not only that, the CMS went in and did an audit on them.
Oh boy.
So,
They love that. Yeah.
well, it
Oh,
shouldn't
well.
be, but again, the billing that you have should be accurate, and I'm praying for that day to come, because and listen, it's not that I don't have fun at this job, because I'm telling you, I always say and I've told you this, if this fails, I'm going to go out and do comedy, because I have enough comedy. But I just cannot believe in this day and age that we will answer somebody, well, this is what the computer tells me.
Yeah. Again, a training issue, and
Okay.
80 to 90% of all medical bills, every medical bill generated in this country, in the United States, 8 to 9 times out of every 10 times a medical bill is sent out, it's wrong. It has errors. And do you think it's going to be in your favor, the patient's favor? No. It's going to be in the favor of the provider and or the insurance. So yeah,
Right.
yeah. Yeah. So let me ask you another question about, there was a story you told me once about a patient fell at home and had some injuries, and the insurance said that the homeowner's insurance was responsible for paying for that. I can't even get it out. It just cracks me up, right? Speaking of the Dr. Doherty comedy show, I mean, it is just, what, really? Can you tell us that story?
So the patient fell at home in an apartment building, and I guess coordination of benefits got involved from the health plan, because they must have read the notes from the hospital that patient fell at home, sustained some injuries, and they were pretty substantial injuries, where surgery and things of that sort. They denied the stay and said the homeowner's insurance is responsible for this. There's only one problem. It was in an apartment. They didn't have homeowner's insurance. So that was escalated through CMS itself, but before it got to an arbitration, the plan ended up paying the bill, because when we went back and forth there, I tried to explain to them, no one wanted to listen to me either at the health plan, to say, okay, they live in an apartment and I can't go after the apartment building because they fell on a rug in the apartment, but they don't have homeowners insurance. So guess what? Bill is yours.
You're it. Tag,
right, you're it.
Right.
And they just down outright refused. And there was hospital, orthopedics. She ended up in rehab. It was not a fun event. But at the end of the day, after, back and forth working it out, but of course, they'll tell you that the coordination of benefits person did contact me and said, well, no, they should go to the manager of the apartment. I said, that's not going to fly with anybody's insurance. Listen, I'm the clinician. I said, but let me explain something to you. They fell in the apartment. They didn't fall in the hallway. They didn't fall in
Exactly.
the doorway. They fell
Exactly.
in the apartment on a rug. They're not going to pay that. That's not a home. The apartment building's not accountable for that because they don't own the carpet.
That's
It
right.
was the patient's. The bill is yours, no matter what way you want to look at it. The bill is yours. That went back and forth, and I even escalated that up within the health plan, and they stuck with COB, the coordination of benefits, what they were writing. So I said, okay, here we go. We got to go to Medicare, and Medicare said, pay the bill, pay the bill.
Wow. And,
So,
you laugh so you don't cry, but it's amazing that they actually say it with a straight face. And again, I want to say that it's a training issue, because I wouldn't be able to, if it were me and I knew better, I wouldn't be able to say that with a straight face. Oh no, that's home insurance, because that should be the claim for all of the injuries, and all of the medical costs should go to their homeowner's insurance because they fell inside their home. Wait,
Right.
what? And it's an apartment building. And it's like, wait, what? and you're going to come after the patient for it, and not, work out the subrogation, the technical term for that, not work it out directly with the patient's insurance and not the patient themselves. So yeah, it's just, wow,
Well,
incredible.
in most cases, really coordination of benefits, you're supposed to pay it and they work it out with the other insurance. That's how that
Exactly.
really works.
That's the
But
way you leave the patient out of
right,
it. You go with the insurance and you guys work it out amongst yourselves.
correct.
Yeah.
But they did not do that either. And I tried to tell them there is a reg on that, but
Yes.
they just went over my head. So I was like, okay, and now I'm going over yours.
Exactly. We can
And
do this the easy way or
right,
the hard way. The choice is yours.
right.
Yeah.
And I think the longer they feel they can hold on to their money, because what was amazing to me, and it was almost like a slap in the face to the people of the United States, was during the pandemic, health plans made the most money and they had to run out and spend some of it. And I said, of course they did, because nobody went to the doctor, nobody got tested, nobody did
Exactly.
anything.
Exactly.
Except for COVID. So of course, and then I said, wow, wouldn't this be a great time to really look at all your denials and start really looking at them and paying a little closer and maybe throwing the money out that way.
Well, they did. They did. Many of them went back and looked at if there was appeals for the denials. They will look at it and say, well, yeah, we'll pay for this. We'll pay for that, because they had to start spending some of that money because of federal law, the ACA, the Affordable Care Act, what folks call Obamacare, saying there has to be, for insurance companies, you have to spend a certain percentage of your revenues in direct patient care and paying providers for direct patient care, as opposed to administrative costs, paying for the medical directors and the vice presidents and all that fancy stuff. So they realized that nobody was getting care. So they hadn't been paying anything for a year or 2 years. So they had to start paying some stuff. So yeah, some stuff that they initially denied, oh, well, no, we'll pay for that. And we'll pay this higher, well, we usually only pay this low rate. Now we'll pay you a higher rate, because they had to, spend some of that money or they'd have to give it back.
Well, the other thing too was, now I don't know if you've come up against this, but I have with the COVID. So the diagnosis is COVID, and I guess they don't have the exact coding yet on that.
Exactly. Early on in the pandemic. Yes.
So they're denying the bills. And I'm going, well, how's that work? Because they were pretty much in the ICU. So I said to the hospital, all right, if I'm in respiratory failure, why can't we use that if you don't know really if you don't really know if it was attributed to their COVID or
because
whatever.
COVID testing, number one, the COVID tests early on weren't available, weren't plentiful throughout the country. That was the first thing. The second thing is they didn't have the CPT codes yet assigned yet very early on for the COVID test. So yeah, early on in the pandemic, somebody sucking on a tube, intubated in the ICU for 2 weeks. You think that may be COVID just because it was early on and we didn't have the tests and we didn't have CPT codes for the test. Yes, you're going to go back and you're going to fight to say, yeah, that's covered under a COVID workup, treatment, and diagnosis, or I should say diagnosis, workup, diagnosis, and treatment. Yes.
So a lot of those bills are still fighting mode too. I have a couple of those are still in fighting mode. That definitely, you have COVID there. You didn't have a code. Now you got the code, recode the thing.
Exactly.
Recode the bill, I said, because the patient's not paying this bill, because a lot of it is the ICU and intubation. And believe it or not, it's families coming to me with deceased family members that they're being, I know, it's just, yeah, and they're suing the estates. And I'm like, well,
they come after the estate. No.
Can't really do that.
Yeah, exactly. Another story you told me about, Dr. Doherty, was about a hospital that actually sued one of your clients. A client came to them that was suing them for tens of thousands of dollars. And it turns out when you dug into it, they were suing them for many services that the patient had never received. The patient, the providers, the facility never treated the patient with these particular services or procedures that they were billing them for.
Yeah. So what happened was they received the bill, but you know what was even funnier? The explanation of benefits came from Medicare, and there was only one problem. The patient, the family member that the bill was for, he was never in the hospital.
Whoa.
Yeah. So was it fraud on behalf of the hospital? Did they mix something up from years ago? But having that said, we're trying to explain to them that this never occurred. They didn't want to hear me. The bill is his, blah, blah, blah. So finally, at that point, I didn't really know who to go to, because Department of Health, they're going to say, work it out. I went to the Attorney General and I said, I want to show you something. And I worked with one of their reviewers in the healthcare division in New Jersey. And I said, listen, here's the explanation of benefits. Here's the bill. There's only one problem. The family's telling me he never was in the hospital and never had this surgery. He was never even in this facility.
Was
So
he in the emergency room or something? I mean,
no,
why did
it was just, it was a surgical.
so an outpatient visit,
Inpatient.
inpatient, and
Inpatient.
he was never anywhere near the facility, didn't visit an emergency room or
But they
department
wouldn't listen
related
to
with the
me.
system at all on that day.
Nope.
Wow.
And you know what's really funny? And now that you're talking about this, I don't know if you know about Seven on Your Side.
Yes.
Somebody else that happened to just this week at Montefiore.
Wow.
So I guess they might steal the cards or whatever, and they use them.
Sure.
But
Oh, I forgot about that. Of course.
yes,
Health
but
ID fraud, health insurance fraud, ID fraud,
right.
medical ID
So,
fraud.
so
Wow.
but the thing is, the hospital would not listen to me. The bill is his. I'm trying to explain to you one more time. And then I called up Medicare and I said, this is what happens, blah, blah, blah. The same story I'm telling here. And I said, I did report it. Here's the reviewer at the Attorney General's office. So they worked together, but it was them together coming after the hospital to say, this wasn't your patient. And the other piece of that was the surgeon who worked on him. We took a picture of him to bring to the surgeon, and he says that wasn't the patient.
Oh, wow. So that really was health insurance ID fraud.
Yes.
Wow.
But they should have listened instead, because now this could have been a lesson that says this is why it's so important to get picture ID when you get these insurance cards, like when you come in. But you know what was really funny? They didn't do it that day for the surgery. They didn't take, like they'll ask for your license with your picture ID. Yes.
Uh-huh.
No, because it wasn't in the chart.
Wow.
So yes, so
Amazing
that was
stuff.
that was a hard one, upsetting to me, because it was like I really had to figure it out, because I did talk to somebody and then I'm saying, you can't really let this go, because the families, and I looked at the chest to make sure he didn't have heart surgery, that maybe they might have been screwing with me. I don't know. I just wanted to make sure.
You were looking for the scars, huh?
Well, like I said, listen, would it be okay to look to see if he He said, go for it, because it was heart surgery, but the
doc billed for heart surgery that he didn't have. And you're like, can I look to see the scars where they cut open your chest for your heart surgery? And they weren't there.
Right.
Yeah.
So what was funny, though, was the surgeon did do somebody's surgery that day, but it wasn't this guy.
Oh, wow. That is really
he did
something
use
else to look out for. Not just medical billing mistakes, but medical billing fraud because someone stole your health insurance ID.
Well, that's why I tell people, listen, just keep an eye out on those explanation of benefits, because if you do get it and you did not have those services, you need to contact Medicare right away, or the insurance company. And the reason being is that goes against your lifetime benefit in the Medicare world. And then in the other, it goes against your benefit. So what if you really do need that type of surgery down the line? They're going to go, well, wait a second, you had that done already.
Right. Years later, when you're like, wait, what? and it's going to be much, 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 much harder to dispute. So
Right.
yeah, the EOB or explanation of benefit, when you get an EOB, look at it, just turn it over the back to the back and look at each claim or each segment that says you received a service and make sure you receive that service.
Right.
For Medicare, the EOB is called an MSN or Medicare Summary Notice, and you get that every
Right.
3 months. Turn that over and make sure that over the past 3 months, you had each of those services. Now, Medicare has gotten hip to that over the years, and every once in a while, you'll get a survey and say, hey, did you have this in this procedure? They'll just do like a random audit. They'll send you a letter and they'll say, did you have this in this procedure on such and such a day? So I noticed they do that for Medicare. And I think they're starting to do it. Some commercial insurance plans are doing that. Private insurance plans are doing that. Just want to double check. Did you have this on such and such a day? We're taking a survey. So, it's helpful if you can, just be ahead of the game, check the documents that you get, your EOBs, explanation of benefits, and or MSNs. If you have Medicare, your EOB is called an MSN, Medicare Summary Notice. Just flip it to the back, make sure that's you, that you had all those procedures. Wow, good stuff, Mary D. Dr. Doherty, you're the bestest. I just love your stories. I love your comedy show. I love the Mary D comedy show.
It's just, in this world, it's hard enough to be ill, but to have to deal with this, sometimes it's just heart-wrenching to watch. For me, it's just heart-wrenching. And it's just, it shouldn't be to this extent, especially, when you're sitting there and you're trying to recover and your family, now you're thinking your family's in jeopardy. And I'm like, no, don't worry about it. We'll get it done. Don't worry.
Your family's home, their shelter, everything that you work for, there's your savings that you wanted to leave for them and take care of them, put your kids and grandkids through school. Absolutely. Wow. Yeah. You know what? We talk about that this is funny. We laugh about it. And we say, you know what? You should go on tour and do a comedy show, the Mary D comedy show. But, seriously, we laugh so we don't cry, to your point. And it's important stuff. I can't thank you enough, Dr. Doherty. Can folks still find you at Mary@GHP Navigators.com?
Yes, that's my email address. Right now, our website is under construction.
Okay.
So I
As
don't
long
have
as we can get you there at Mary
Right.
at GHPNavigators.com.
Right.
We'll take that. Awesome.
Great.
Thank you, Dr. Doherty. I think you're the bestest. I really appreciate you sharing your stories with us and educating us. Much appreciated.
Thank you. You have a great day, everybody.
You have an awesome one. Take good care.